Welcome to Get Briefed Podcast, the latest MDBriefCase group offering developed to inform healthcare practitioners regarding a variety of relevant medical topics. This podcast is available at www.mdbriefcase.com. The views, information, and opinions expressed in this podcast are solely those of the individuals involved and do not represent those of MDBriefCase. This podcast does not constitute medical advice and is only meant to educate and inform the listener. Please enjoy.
I'm Dawn Rae Downton. Today, in the final podcast of our 7-episode series on treating chronic pain, we're talking about cannabis. Humans have been treating themselves with cannabis for thousands of years, and not without controversy. In 2001, Canada laid claim to being the first country to adopt a system regulating medical use. We've come a long way since then. Today, via a prescription or a dealer, Canadians can get cannabis in capsules, lozenges, tinctures, drips, and oils. There are cannabis-infused skin patches, creams, and lotions. You can get sprays to mist the inside of your cheeks or your skin. There are even synthetic versions. Nabilone, for instance, was greenlit by Health Canada way back in 1981 to counter chemotherapy-induced nausea, vomiting, and anorexia. Varieties of so-called edibles, including cannabis-infused drinks, seem to be limited only by the imagination of cannabis chefs. And as we all know, you can inhale cannabis by smoking or vaping dried buds. But what actually is it good for other than to bring you a mellow, slow-mo evening that dials back a chaotic day? The Chinese word for cannabis, after all, means numbness. Well, we're told to try it for everything from calming GI upsets to increasing appetite, improving mood and sleep, treating tics, glaucoma, muscle spasms, and MS, for which it's an approved treatment in at least 10 countries around the world. We're hearing a lot lately, especially as opiates fall out of favor, that cannabis works on chronic pain, which is what we're going to be most interested in today. At least 27 countries have legalized cannabis, or at least one of its components, cannabidiol, or CBD, for medical treatment. That's true as well for, at last count, 46 U.S. states and the District of Columbia, though not, of course, for the U.S. itself. So, lots and lots of cannabis out there, with more coming to Canada with legalization for recreational use, and still lots and lots of controversy. More controversy than ever, perhaps, especially when it comes to evaluating the evidence and determining whether or not cannabis can replace opiates or dial down their use. Can it help your patients? Can it hurt them? The answers so far seem to be maybe and maybe. What evidence we have is almost entirely anecdotal, coming from what patients say and what you see and hear in your practice, whether or not you prescribe it. We know what we think we know from YouTube science, if you will. That's because cannabis hasn't undergone much formal study. Regulations and traditionally heavy restrictions in Canada and the U.S., even when it comes to research, have gotten in the way. A researcher at the Pain Clinic at Halifax's QE2 Health Sciences Centre reports that he abandoned his cannabis research some years ago because the restrictions on cannabis handling and storage were just too onerous to meet. Dr. Alan Kaplan and Dr. Robert Hauptman know all this and more. Today they're going to walk us through the thinking and the evidence on using cannabis for pain. Robert Hauptman is a pain consultant practicing in Edmonton and an assistant clinical professor with the Department of Family Medicine at the University of Alberta. He's also one of the founding members of the Pain Society of Alberta and the Alberta Medical Association's Chronic Pain Section. Alan Kaplan is a family physician in Ontario's York region. He's also a pain consultant and a clinical lecturer at the University of Toronto. And welcome again to you both.
Thank you, Dawn. Good morning.
Good morning.
Good morning, Dawn.
Good morning. Dr. Hauptman, tell us, exactly what is cannabis? We probably all think we know, but there's an awful lot going on in this plant, isn't there?
Yeah, there absolutely is. So it's an interesting plant. So cannabis refers to the genus. There's actually three species, Cannabis indica, Cannabis sativa, and then Cannabis ruderalis. Nobody really talks much about that particular species of cannabis. Mostly you hear about the indica and sativa species. The actual plant from seed to harvest is about 100 days with a lifespan of about a year. The female plant is what secretes a lot of resin, which is very rich in cannabinoids. But interestingly enough, all parts of the plant may contain cannabinoids except the actual seed. It's the cannabinoids we're actually interested in. Cannabis itself actually has roughly 400 compounds in it. The majority are actually non-cannabinoids that we really don't know a ton about. Of the cannabinoids, which there's roughly 60 to 70, the ones we are most interested in, at least at this point in time, is THC, which is tetrahydrocannabinol. That's the psychoactive component of the cannabis plant. And then cannabidiol, or CBD. That's the component of the plant that is clearly not psychoactive, that may have medicinal benefits. But as you pointed out, as I'm sure we'll get into as this podcast goes on, there is not a lot of really good scientific data when it comes to CBD. There is when it comes to THC, but it appears to be distinctly different in terms of what it does to our patients. I think most of the interests that people like myself and Dr. Kaplan have are really in the CBD. What can that actually do medicinally for our patients? But unfortunately, again, that's where the least amount of evidence is when it comes to the scientific literature.
And what about the strains? You mentioned the indica strain and the sativa strain, and then the third, which we don't hear much about and probably don't care much about right now. What is the difference between, say, indica and sativa? Is one good for since the cannabidiols or since the cannabinoids are, as you say, dispersed throughout the plant? Do you get the same level of cannabinoids in indica as you do in sativa? What's the difference?
That's actually an excellent question. There are over 1,000 strains of cannabis, and there's been a lot of genetic modification of the plant over the year to produce plants that are extremely high in THC. People try to get stronger strengths of THC to get more of the psychoactive effect. Now, to, shall we say, the marijuana connoisseur, indica and sativa is supposed to give different types of responses. One's more supposed to be stimulating, the other more kind of neutral. However, that being said, if you look at the evidence between those broad strains, the indica and the sativa species, it really still has to do with the relative ratios of THC to CBD. If you have a plant that's high in THC, it tends to be a bit more psychoactive. If you have a plant that's high in CBD, it tends to have more of an anxiolytic effect. So that seems to be where the real components are. There are a few other things to the plant that the non-cannabinoids, like trichones and things that give it flavonoids, that actually give it the plant the flavor and the smell that you have that it kind of distinguishes between the indica and sativa. But really, from our point of view as clinicians, it really is the ratio of THC to CBD that is most important to us, not necessarily indica versus sativa.
Dr. Kaplan, we're getting into Dr. Hauptman has just mentioned some of the properties that are thought to adhere to CBD and THC. So we're getting into this question that I want to ask you. Clinicians, what conditions do they think that cannabis might work for?
Well, cannabis has been purported to work for a variety of conditions, but the evidence for most of them is actually quite sparse. There's even evidence as far back as for glaucoma, but apparently you'd have to be smoking it all day in order to reduce your intraocular pressure, with RCT showing that 1 out of 6 people would have some benefit. But overall, what's looked at even more so is that for pain, seizures, nausea, vomiting, spasticity, and post-traumatic stress disorder. So let's talk about neuropathic pain, first of all, where really most of the evidence for the work that Dr. Hauptman and I would do is in this. And there's been some recent colloquial guidelines created by this, looking at the evidence for that, authored by Dr. Michael Allen Group. But what it really did show is that while there is some benefit, this evidence is not across the board for everyone. And it's going to be, probably about, really a number like 30% of people are going to have benefit from this, where most may not. Seizures in children is something that's a little bit outside of my particular evidence group. Dr. Hauptman may know a little bit more about it. But for refractory seizures, there's been a lot of use of this done by some of the super specialists. It's not something I do in my practice. For nausea and vomiting, first a lot of the treatment was done there for post seizure and post chemotherapy, and there certainly was some evidence for that. And again, anywhere from 30 to 50% of people will get benefit that way. There's some evidence for spasticity and people with neurologic conditions to reduce some of the spasticity that occurs in those conditions. And the last one, which gets purported a lot, is post-traumatic stress disorder, that if you use it, it's going to help that condition. There's been a number of small studies with outcomes for that, but I'm very cautious about that because really any psychoactive product will initially improve the symptoms of post-traumatic stress disorder, but that doesn't mean the symptoms will be abated for a longer period of time. And the last thing, which we'll talk about a little bit later, is in the pain world itself, can it be used as an opioid-sparing treatment?
Okay. So I would add to that, just taking a step back, that a lot of the studies looking at marijuana have dealt with THC-predominant strains. And the reason this is that is basically what you've seen in the black market, or shall we say the street market. And the reason why we see THC-predominant strains is that if you add CBD to the marijuana strain, and to be clear, normal, natural occurring marijuana has both THC and CBD, what they find is that when CBD is in the strain, you get less of the psychoactive effect, you get less of the high. So over the years, people who have sold street marijuana on the streets have been genetically modifying the plant to have less and less CBD. So you have this predominance in the marketplace, the street marketplace, the illicit market, shall we say, of high THC strains of marijuana, and that's what we have most of the data from. We do know that THC does appear to be pro-motility, and this is where you're probably getting the anti-nausea effect. But the effect of THC on pain is very interesting. If you look at studies where you compare people who are marijuana experienced to people who are marijuana naive, and you separate out the marijuana naive patients and ask them have they had benefit, and this is whether benefit, particularly in terms of neuropathic pain, there's almost no benefit to people who've never used marijuana before. And I think part of the problem, and this is so important to clinicians, if they can take one thing from this podcast, is a lot of people attribute the psychoactive impairment of THC with benefit. So it's kind of the same amount of benefit. If you're a pain patient and you drink enough alcohol, you're going to not care about the pain as much. You might even think the pain has gone down a bit, but it's really not as much of an analgesic benefit as it is an impairment. And I think that's really what THC does in the similar circumstances. And that's why people who are marijuana experienced, when they have pain, they take a THC-predominant strain, they'll claim some benefit, whereas those people who've never used marijuana, they actually don't like that impaired feeling, and in studies don't report a benefit. Now, to be clear, that seems to be distinctly different from what we're seeing in CBD clinically. Unfortunately, a lot of the evidence we have now are from clinicians who use a lot of CBD-predominant strains. They appear to give analgesic benefit without that psychoactive benefit. We know that CBD clearly is not psychoactive, but again, if you want myself or Dr. Kaplan to point to a study saying, hey, CBD does reduce pain, you're going to be hard-pressed to find a good clinical study showing that.
Right. So does that suggest then that if it works for pain in people who don't mind the impairment or perhaps invite the impairment, that there's a trade-off to be made between being impaired and treating pain, or is there something more going on?
Well, I think, Dawn, it's important that as clinicians that we actually are working towards not impairing our patients. Impairment from any substance, whether that's a pharmaceutical agent or a natural pharmaceutical agent, shall we say, like the cannabinoids, particularly the herbal cannabinoids, the marijuana plant, this is something we don't want as an outcome for our patients. We want to be able to give them products that relieve the symptoms we're trying to relieve, and predominantly in this case pain, without giving them impairment. And this is why even drugs like gabapentin, for example, can be a problem. For some patients, gabapentin is very impairing, and even if they get a pain response from that, we would approach that as being a very negative outcome. We'd say, geez, that's not what we're doing. And I've had patients who had reductions in pain, and I'm sure Dr. Kaplan has as well, who couldn't tolerate the cognitive side effects. So I think we have to be cautious when we are impairing our patients rather than reducing the pain. And I try very specifically in my clinical setting when people come in and they say they've tried marijuana in the past and it really helped their pain and they want me to prescribe it. I really want to tease that out because particularly prior to the wide access in dispensaries in Canada, a lot of those strains that patients were trying were strains they got from friends, strains from the street, and they really were confusing impairment with analgesia. Now, one might argue that when we're dealing with a bad condition like sometimes intractable and severe, let's say, neuropathic pain, that it's okay to impair a patient, to treat them almost palliatively. But I think there's a better solution here, and I think that solution is trying to get a bit more focus on the CBD strain.
Let me ask you both then, if you talk to staff at Health Canada licensed producers of medical cannabis, they typically say, if you phone up and you say, I'd like to get a high CBD strain because I just want medicinal effects, whatever they are. I want to lessen my pain. I want to sleep better, and I want to come back to sleep in a minute, by the way. If you talk to licensed producer staff and say that, they will typically advise you to get a strain that has at least a little THC in it. And what they say is that this is necessary, that the THC is necessary as a kind of trigger for the CBD effects, which don't happen as well or at all on their own. Have either of you run into that and want to comment?
Well, there's natural antagonism that occurs between THC and CBD, so that there is some balance to the effects by having the other drug, and it just seems to be that you need that little tiny bit of THC to modulate some of the effects of the CBD and make it more effective. The loss of that antagonism by just having pure one or the other will lead to more side effects and poor tolerability. So we do need a little bit of it. The trick of this, of course, is the amounts of it. And because THC is responsible for more of the euphoria and cognitive impairment that occurs, we have to be careful of that. In addition, THC is also responsible for more of the cardiovascular effects, like the tachycardia, which is also being blocked a little bit by the bradycardia. So some of the actual physical effects of the plant are also modified by the ratios of the two components.
And I agree totally with Dr. Kaplan in this regard. And thankfully, there are a lot of producers, ones that I think tend to focus a bit more on the medicinal market, who are producing strains with as little as 1 to 2% THC and upwards of 20 to 25% CBD. And this is particularly in my practice of over 500 patients now on medical marijuana. The vast majority, probably in the 95% range of my patients, use these very much predominant CBD strains, but again with a small amount of THC. Now, of interest, just a little aside, which our audience might be interested in, there was a clinical study that was done with a synthetic CBD. There was a company in Germany that was developing a pure synthetic CBD compound, and it actually did make it to clinical trials. The problem was that in the group that took it versus placebo, there was actually a higher risk of death. So there might be truly a reason that there needs to be a bit of THC with CBD to give the therapeutic effect we're looking for, and as opposed to a negative effect, and certainly negative effects such as fatality.
Mm-hmm. I think it's important for both patients and doctors to realize that what we hear called CBD oil so much, we hear a lot, at least I do, that CBD oil is a good medication for pain in particular. It's not actually CBD oil, as we've been talking about. If you actually look at what you get from a licensed producer and actually what you get from some dealers, it's cannabis oil, and it has some THC in it. So I just wanted to underline that point that clinicians who think that they might be prescribing CBD only for their patients in a CBD so-called oil are not. They're actually getting cannabis oil with a little bit of THC or perhaps more than a little bit in it. I did want to come back to the question of chronic pain from the patient's point of view. I hear, and other people can back me up on this who have done surveys of patients using cannabis. I hear frequently that for certain kinds of pain conditions, at least, cannabis, whatever the THC CBD combination is, flares it, kind of, puts your attention on it more than you want your attention on it. But it turns out that many chronic pain patients like cannabis for sleep. Their sleep has been impaired by their pain. They can't get through the night without waking up in pain. But there's something about some strains of cannabis, CBD heavy, a little bit of THC in them, that seem to work really well at getting people to sleep and keeping them asleep. Have you, Dr. Kaplan, can you comment on that? Have you seen that at all in your practice?
Yeah, I've got some patients that use medical marijuana just for nighttime to help them with their pain/sleep. And I think that's something that we do see. Once again, it's going to be the appropriate balance of the THC for the CBD. Having some cognitive impairment at nighttime is a trade-off for sleep. It's not unreasonable. The quality of the sleep becomes a bit of a question in terms of are they actually getting into the proper REM sleep that we need. But for patients who are actually lying awake in pain at night all night long and suffering with that, that's a trade-off that I personally am willing to make. And it's probably one of the only times that I'll take my THC concentration higher because I do not want impairment during the day. So I think there is certainly some benefit from there. There is some anxiolytic effect of the medications as well. So as you're lying in bed in pain and getting anxious about the pain and not sleeping, the fact that you have that anxiety relieved and allowing you to sleep is probably partly how it works.
Dr.
I would 100% echo Dr. Kaplan's points in this as well. One of the few times I'll actually use THC is at night because it does help some people to sleep better. Now, sometimes you can still use a predominant CBD strain if it's really intense pain that's keeping them up, because CBD appears to be both analgesic and, as Dr. Kaplan pointed out, it does appear to be an anxiolytic as well. And so that's not unreasonable. Sometimes I find the balanced strains, these are strains that are, roughly proportional in a 1-to-1 ratio, THC to CBD, has to be used because you need a bit more of that THC to get them to sleep at night. I do also, though, want to go to a point you brought up, Dawn, which is so important. I have found with too much THC, as you noted, that there is a certain, hyper-awareness people get of their pain, or, quite frankly, hyper-awareness of their mental health problems. And that's where sometimes a high THC strain is not only worse for pain, but it's also worse for things like anxiety and depression. So, again, I think we have to be very, very cautious. There is clearly a recreational market out there that is pushing high THC strains. And I think it's so vitally important that we as clinicians try to push our patients away from that market, because I think that market's going to do, quite frankly, more harm than good. The other thing to that point is keep in mind, and again for our audience, that back in the 60s, the street marijuana had THC levels of roughly 1 to 3%. Now you can typically see street marijuana strains in the 20 to 30% range, and certainly some of the resins like shatter are well into, I've heard, as high as 80 to 90% range, really, really high potency THC. This is something medical patients absolutely need to avoid.
Yeah, good point. Thank you. Dr. Kaplan, you were the one that brought this up, so I'm going to go to you with this, and I will obviously also ask Dr. Hauptman to weigh in. The whole business of whether or not cannabis can somehow replace opioids, or, as you put it, be an opioid-sparing treatment, noticing the media and the research over at least the past 18 months, you become aware that seldom are opiates mentioned where cannabis is not also mentioned. And certainly the contention seems to be that opiates are bad, that cannabis is probably okay, hasn't hurt us in thousands of years, won't hurt us now, and is really good for pain. That seems to be the popular press story out there. What is the real story? Dr. Kaplan, we'll start with you, as I say. Is cannabis going to be useful as an opioid-sparing treatment?
Well, thanks, Donna. Our new reality, of course, is that our colleges are insisting that we attempt to taper down patients on opioids. And in order to do so, certainly this can be done by just tapering opioids and seeing how patients do. But oftentimes we have to actually add something to their armamentarium to allow them to help them through this reduction in medication if they're able to do it at all. So this is the reason why cannabis has been looked at as one of the opportunities to assist in opioid reduction. The data in the literature is not great on this. There has been some studies on it, and it shows some reduction in opioids depending on the different trial. One trial I saw was as high as a 60% reduction. It depends a lot on the kind of pain that's being used. So patients with things like fibromyalgia tended to have better effect than some other pain syndromes, and possibly related to the type of the pain that's happening and the degree of pain centralization in terms of cannabis being effective there. It's also been shown to be able to reduce the need of some of the other medications, such as NSAIDs and even antidepressants in the proper populations. So there's certainly some evidence there, but the evidence really, I don't think, is fantastic, and it's certainly not something you can count on 100%. Not all patients can tolerate cannabis, not all patients want to take cannabis, and not all patients get the benefit we expect. And the last of this is on a bit of a political note, and as you said in your introduction, there seems to be this thought that opioids are bad and cannabis is good, and I actually think that some of the drive towards opioid reduction may well be pushed by this enormous cannabis market and companies out there that are pushing the sales of this. The stock prices for cannabis have gone through the roof. There's a lot of money pressure for this to be a successful industry, and the only time we've had monies up and down like this in the stock market, other than cannabis, other than the tech market, has been in alcohol years gone by. So we have political pressure, we have personal pressure, we have financial pressure to make this an effective product. But in my practice, do I use this? Yes, I do, but with variable efficacy.
What about you, Dr. Hauptman?
Yeah, so again, totally agree with what Dr. Kaplan is saying. My personal experience with a fairly large pain practice is that 95% of patients who tolerate the cannabis we use, particularly the CBD predominant strains, will be able to reduce their medications overall to some extent. It is wrong to think that they are able to totally get off their medications. I see that in about 5% of my population. But the vast majority have continued on what they've been on in the past, whether those be the antidepressants, the anticonvulsant class of drugs, or quite frankly, the opioid class. I do see patients who need less breakthrough medications when they're on cannabinoids. So I guess that certainly does imply a bit of an opioid-sparing effect. Reductions in opioids, maybe 10 to 20% in terms of dose reductions in the patients that I've had on cannabinoids. To be fair, not everyone. Some people, need the combination. There appears to be a synergistic effect because we are talking different receptors. The opioids work on the mu-opioid receptors. Cannabinoids tend to work on what's called CB1 and CB2 receptors. So there does appear to be this synergistic effect. Like Dr. Kaplan, I 100% agree that the literature is not clear. I've seen some published reports on an opioid-sparing effect, but really the data is not robust by any stretch. And like Dr. Kaplan, I want to echo, the politics behind this and, how big business may be driving some of the, mythology out there. Even the mythology that no one's ever, for example, died of marijuana. And while it's true that the plant itself is unlikely to directly have killed anybody ever, there's certainly secondary causes, and things like impaired driving and impaired driving-related accidents and deaths are something that you just don't hear a lot about, but there's clearly that potential there, and I'm sure it's happened in the past. So, the idea that marijuana is 100% safe, 100% is not going to cause any morbidity or mortality to our patients is false. Nothing's 100% safe. And again, like any therapeutic option we have in medicine, we have to look at the risks and benefits in any given patient. One just anecdotally, just example of this in my own practice, with a patient. I had two patients recently. One was 40 and one was 80. Both using cannabinoids for pain, more of a bound strain. Both became psychotic, surprisingly. We think of that in the younger population, but both started to experience quite vivid hallucinations. And there was a question of whether or not they were septic or whether or not there was a new thing going on, another disease going on. And as soon as we stopped their marijuana, their hallucinations went away. So, again, this happens, and we have to be ready for this.
So are you saying that this is a different kind of hallucination from those that you get with THC? I mean, many people, there are hallucinations involved in imbibing THC. Was this something different, that an effect that they were exhibiting while they were not actively under the influence of the cannabinoid?
No, this was. They were experiencing. I mean, there's a differential diagnosis when it comes to somebody who starts to experience hallucinations. These were people on relatively stable doses of their marijuana preparation who started to exhibit this. And this is beyond just a lot of people who take marijuana. It's more of a euphoria or a feeling of calmness to get to the point of actual hallucinations with marijuana. Is significant and what I would consider an impairment. I don't think that most people who use marijuana actually want to get intense visual hallucinations, and these are what these two patients developed. And again, surprisingly, along the course, they initially started out, they seemed to be getting a therapeutic benefit, and then subsequently started to have these hallucinations. So I think this is a word of caution. We haven't spoken too much about side effects at this point, but there are side effects to medicinal marijuana that we have to be aware of.
That was where I was going next, and I'm going to go back to you, Dr. Kaplan, and let you start out talking about what are the dangers that you think are out there for patients using cannabinoids.
Every medication, both the natural or pharmacologic, is going to have potential side effects. Dr. Hauptman's already talked about the psychosis aspect. One of my jobs is I do medical care in a psychiatric facility, and every day we admit someone with the effects of cannabis to the hospital with psychosis. Either someone who's got schizophrenia that's been worsened by it, someone whose schizophrenia has been activated by it, or someone who does not have mental health illness at all, but has, as for Dr. Hauptman's case, has developed psychosis while taking the medication. Now, therapeutically, one of the questions I ask before I consider giving marijuana to patients is, have you ever used it in the past? Have you ever had a, quote, bad trip, end quote? And those patients are ones that have already told me that they're going to have psychosis with cannabis, and therefore it's not a good choice. That being said, most of the psychosis happens because of the THC, not so much the CBD, even though, just as Dr. Hauptman, I tend to use high CBD pretty well exclusively. But CBD itself has actually been shown to possibly have some antipsychotic effects, which is kind of interesting in itself. But overall, a history of psychosis or the development of psychosis is a contraindication to using cannabis. So that's one issue. Moving down the road is the cognitive impairment we talked about. And that moves beyond just cognitive impairment when you talk about youth. When you're talking about youth and developing brain and use of cannabis, this is a disaster waiting to happen. There's been good evidence that shows that it decreases hippocampal formation and development and will lead to poor psychosocial performance and cognitive impairment in youth. There's the concern about addiction, and we can talk a little bit more about addictive screening, but addiction to cannabis occurs, and cannabis dependence syndrome also occurs. There's endocrinologic effects, there's reproductive effects on testosterone suppression, sperm motility, elevated prolactin. There's funny conditions that we've just started learning about, things like hyperemesis syndrome, where people have been on cannabis for a while start to have episodes of repeated vomiting that's related to the cannabis itself as a delayed side effect. There is the fact that it's completely unsafe in pregnancy and in breastfeeding because it is lipophilic and will go through to the breast milk to the baby, and has been shown in pregnancy to have lower birth weight, shorter gestational period, abnormal startle response, tremulousness in the baby, smaller head size, and then problems with deliveries and premature labor. There has been some relationship, potentially even to attention deficit disorder in these children down the road, and of course while they're taking it. It's also, as it's used often in the inhaled route, we absolutely know that this has effects on the lungs. The effects on the lungs would be worse in asthma or COPD, or to cause bronchospasm in itself. Amazingly, it's purported as a treatment for bronchospasm years ago, which doesn't work. There's an increased rate of lung cancers, but also head and neck cancers with this. And that's just all from the inhaled cannabis itself. Something that also we have to be considered about is the fact that many things contaminate, especially stuff that's bought on the streets. And we're just reviewing the respiratory effects of cannabis for Canadian Thoracic Society guidelines on this. And the data for this is quite scary out there. It can be contaminated with aspergillus and other fungi. It can cause eosinophilic pneumonias. There's even a condition called vanishing lung syndrome, where the lung basically gets destroyed because of inhalation of contaminants and other drugs of abuse, unfortunately. So I'm not even sure I've hit all the downsides here. Dr. Hauptman also talked about motor vehicle accidents and cognitive performance that way. And then, of course, there's cardiovascular effects that I've mentioned already. It can cause tachycardia and hypertension and causes increased risks of cardiovascular events. So that's quite the list of adverse side effects. And I think that's as Dr. Hauptman said, that we have to talk about the pros and the cons of anything. And I'm hoping that at least the fact that it's a legislated, a company-based treatment where at least not on the streets you're going to have, quote, pure, end quote, a product and not have some of the contaminants. But I'm very afraid of what's happening, what people will inhale on the streets. And therefore, if I am going to use this at all, I try very hard for patients to get this only from a licensed producer where at least I have some idea that they're going to get more pure treatment formulations.
Although I would point out that there is a class action lawsuit in Canada right now against two licensed producers who were purporting to be selling organic cannabis, which turned out to have been contaminated by a fungicide that causes cannabis when heated or lit to turn into cyanide. So that's a little unfortunate. So there is a class action going on, and that product was from licensed producers. So it's not, I guess we hope that licensed producers have a cleaner product, but they don't necessarily have a cleaner product. Want to go back to the dangers, Dr. Hauptman. That was an encyclopedic list that Dr. Kaplan gave us, a kind of a sobering encyclopedic list. Did you have anything to add to it? Did he miss anything?
No, Dr. Kaplan hardly ever misses anything. And that was certainly an extremely robust list. I will add two comments, though. One is the cognitive impairment, which I think is important to keep in mind. It's been noted that IQ may drop as much as 10 points in people that use it under the age of 25, and 10 points is fairly significant. If your IQ is, let's say, 85, and normal is 80 to 120, or what we consider normal, and you go from 85 to 75, you pretty well put your intelligence below the average IQ. So this is a significant thing that we need to be wary of, particularly in our patients under the age of 25. With respect to use of marijuana in pregnancy, I could not agree more with Dr. Kaplan in this regard. We know that there's a push among pregnant patients to use THC for nausea and vomiting in pregnancy, particularly in the first trimester, when the baby is developing the most. This is a nightmare and should be absolutely condemned by healthcare practitioners. There is clearly much safer products to be used in the first trimester to help nausea and vomiting. So again, back to this idea that just because it's natural, it's safe, nothing could be further from the truth. The final comment I want to make, and I think we've kind of alluded to this in this presentation, is that in my practice, and many of us who use medicinal marijuana, and I'm sure Dr. Kaplan will agree on this point, we tend to discourage vaporization as a means of taking the product. So we tend to use oils. There's now capsules available. Very few of my patients are vaporizing marijuana. There are a few exceptions. I certainly never approve smoking it. When you smoke marijuana, it's been said that you release as much as 50% more carcinogens than tobacco. That's significant. So vaporization, where you actually put it into a device that actually heats it, it doesn't actually burn the marijuana, but heats it, and that therefore releases the oils. It's safer, but ultimately anything you're inhaling has the potential to have a negative effect on the lungs. And also there's a dosing problem whenever you take something by inhalation. We really just don't know how much our patients are getting. So as a clinician, I prefer the oils and the capsules when we can actually more precisely dose the amount of marijuana the patient gets. Which, to be fair, just again for our audience, I'm not sure if we'll come to this point, but we haven't really talked that much about dosing. In my very large clinical practice, very few patients, maybe 1% to 2%, use more than a gram a day. And this is significantly important to understand. Gram a day kind of runs about 2 joints. It's about what you're talking about here. A joint roughly is 500 milligrams. There are people out there who are requesting 3 grams, 4 grams, 5 grams, 6 grams, 7, 8, huge amounts of marijuana. And in these cases, we have to think back to the potential for cannabis abuse disorder, which happens roughly the same amount of people who use cannabis will develop a substance abuse disorder as people who use alcohol. It's roughly 10% of people who are exposed to the product will develop a true abuse disorder, and we have to be very aware. And these are people who are using, really excessive amounts. So a word of caution to practitioners: if your patients are asking, "Hey, I want a medical license for 6, 7, 8 grams of marijuana a day," this is way outside the norm, and the vast majority of people who are going to use this for therapeutic reasons are going to be using a gram a day or less.
Dr. Kaplan, just before I come back to you for comment on that, if you have any more, just wanted to say that it reminds you there was a hue and cry last year from about veterans when they were reduced from 10 grams a day, which they had been allowed, to 3. And there was, as I say, an outcry about that. But it would seem clear that 10 grams a day is excessive. Dr. Kaplan, what do you think about that?
I have, right now in my practice, I have one person on 5 grams a day, and he's my exception to the rule. So I completely agree with what Dr. said. I think we have to sort of go back to the principles of addiction and so on, and cannabis dependence. And remember the 4 C's that we talked about in the other programs: the loss of control, the compulsive use, the craving, and the use despite consequences and family concerns. And these are the questions you have to ask both of the patient and of their family for someone who's wanting those kind of doses, and perhaps any doses of cannabis. Frankly, my list was still not exhaustive. There's more that I didn't do. There's been a relationship to risk of things like prostate cancer and glioma in terms of case-based database trials. There's been some immunosuppression regarded as well. There's a relationship between the number of cigarettes and the number of cannabis. They talk about one joint is like 5 to 10 cigarettes per day because of the depth often of the inhalation that's used in cannabis when you smoke it. So I'll completely agree with Dr. Hauptman that there's absolutely no place ever completely, adamantly, 100%, if I can make that any clearer, for smoking marijuana as a physician-recommended treatment. I use virtually only oils. Now, as Dr. Hauptman said, there's now some companies making capsules and so on, and you've mentioned some of the other ways it could be made. My one exception to the rule about vaporizers is in someone who's in a treatment for cancer care and I'm treating palliatively. because the onset of activity by inhalation is much faster than by oils, which last much longer, but is slower to onset. So for someone who's getting palliative care, I will occasionally use a vaporizer to be able to get the treatment faster into their system because they need it at that point. But for people who have chronic pain, where you're looking at having levels around the clock to be effective in any product you're using, something long-acting and slower onset is quite reasonable and certainly safer. And the last thing that we talked a little bit about, I think, is driving. And we have to remember the onset and activity of these medications. Vaporizer will work within minutes and last for a few hours. Oils will start working a little slower, but will last for 6 to 8 hours, which means you're cognitively impaired to drive your car after using medication for as much as 6 to 8 hours. Something to consider for anyone who's using it.
What do you both think of these people who say they're better drivers when they've taken cannabis? They're out there. Let me tell you, they're out there.
Yeah, and I've heard this as well, Dawn, and I think the point is we just don't actually have enough true data. We have to assume that they're going to be impaired. I've read some data that, again, they get that hyper vigilance when they've smoked marijuana, so maybe an increased awareness of what's around them. But we are at this point needing to have some very hard data in terms of the safety of using these products and driving. And until that data is available, the Canadian law, as I currently understand it, is that it's against the law to drive within 4 hours of smoking or vaporizing marijuana, 6 hours if you take it orally, and 8 hours if it made you feel impaired. And this is the law of the country. Now, that law is based upon not on a lot of data at this point in time, but based more on an intuitive feeling regarding this. Maybe 5-10 years from now, when this is looked at a bit more extensively, we'll have some better thoughts around this. Just as a point of contrast, there's always been this question in my population, well, how can you say I can't drive when I use marijuana, but I can drive when I use an opioid, for a contrasting point? Well, opioids have been studied in driving for the last 20 years. They've been extensively looked at in terms of whether or not they cause harm when driving, and we have guidelines on when it's safe and not safe to drive around opioids. But that's because we have really hard evidence for opioids in driving. We just don't have that when it comes to the cannabinoids at this point in time.
I think another way to paraphrase what Dr. Hauptman is saying is that we are, although cannabis has been around for many, many years, we are really very early on in its use as a approved pharmaceutical. And I think we are now where we are with opioids 25 years ago, when we felt that there was no harm to opioids and you could increase the dose because you wouldn't get a GI bleed like you would get with a non-steroidal, wouldn't have a seizure as you would have with some of the other medications if you pushed them up too high. But the opioids did not have that ceiling. We've now learned that there is a ceiling and there is harm potentially from pushing doses high. And I think we're going to learn much more about the harms of cannabis, or as we realize these harms of cannabis, and put them out there for our populations. So be careful out there, people who are thinking about prescribing this stuff, and recognize that there's dangers that despite the list I've given you, there's still dangers we don't even know about, because these are products that we're just learning to use now. And we have to study them, as Dr. Hauptman said.
Dr. Hauptman, you had mentioned just a brief time ago about, we had been talking about which were the safer delivery mechanisms, and you've both said nobody should be smoking this stuff, even vaping this stuff, except in the example that Dr. Kaplan gave us of an end-of-life patient, a palliative patient. I don't know if this is a fair question to ask you. I just ran across this yesterday. It has to do with delivery mechanisms and dosing, which Dr. Hauptman, you pointed out is difficult to identify when somebody is inhaling cannabis. You don't know exactly what they're getting. I just came across this yesterday, and I don't know if you're aware of this at all, but apparently there's research to show that when you inhale cannabis, you get anywhere from 17 to 34% absorption. When you ingest it, you get 6% absorption. Does this suggest, if this is the case, and I don't know whether it is, perhaps you do, does this suggest that you need to take more oil or edible, whatever it is that you're ingesting, as compared to what you would take if you were inhaling it? Dr. Hauptman, let me throw that to you.
Well, you're actually quite correct, and it's very intuitive of you to point out that. That being said, knowing how much is being absorbed, and because you can actually specify the doses, so when we're using, let's say, an oil that's 25 milligrams per mil of CBD, for example, and 1 milligram per mil of THC, when we take 0.1 mils of that, or 0.5 mils of that, or 1 mil of that, we know that's how much the patient is getting, even if they're only absorbing 6 to 10% of that compound. So it's very, very precise dosing. When you smoke or vaporize the marijuana, it really depends how much you've rolled the joint or how much you put in your vaporizer. Even though it's 20 to 30% being absorbed, we just don't know how much. It's really harder to say. I can actually calculate how much you're getting if you're getting it in a capsule or getting it by an oil, just knowing the absorption. So you could, even if you have, let's take morphine, for example, there might be a good example that people might understand. We know that the bioavailability of morphine orally is about 30%. So if you take 10 milligrams of morphine, you're actually only getting about 3 milligrams, but we know you're getting 3 milligrams, and so that's okay. Interestingly, though, I want to go back to a point, and I'm not sure I quite understand why this happens clinically, but I do find that patients who actually use the oils regularly appear not to need a lot of marijuana. Very few of them have wanted more than a gram a day to get a therapeutic effect, whereas with some of the people who are smoking it, they often want higher levels. Now, that may be because, as Dr. Kaplan pointed out, the effect wears off in a couple of hours, where we know if you're dosing it 2 or 3 times a day with the oil, you're getting a constant effect. So that may explain part of it. But it does strike me that the patients I have on capsules and oils usually actually use less marijuana than the people who are vaporizing it.
Okay, let's move on to something that we've briefly touched on. Not sure how much more there is to say about it, but, it's really the elephant in the room, recreational cannabis in Canada. What do you, Dr. Kaplan, what do you think the chief differences are between getting cannabis through a licensed producer and getting it from a dealer? What's the difference between medical cannabis and recreational cannabis?
Well, we touched on that a little bit, and I'm hoping that at least a company that has to answer to somebody would be safer about it, but you have blown the lid off that story of cyanide. But at that point, I still think that Dr. Hauptman and I tend to use a couple of companies, particularly that we've actually had at least some experience with, and we feel that they can do a safe job. I think what you're buying on the streets can, quite frankly, be anything. The question is, what's in it? And while something might be claimed, you don't know what's actually in it. What are the goals of the organization that are selling it? I think the companies, obviously, they're trying to make money, and I have issues with them occasionally, too. They're far from perfect places, but because they sometimes will also try to change people's doses and things like that against what I'm trying to use, and that's been one of my major concerns with them. But on the street, their goal is strictly to get people to take more and more so they can sell more and more. Are they reproducible? Are they safe? Are there contaminants in there? And, of course, the other stories are people who've had their medications laced with other substances. And, again, if you're selling on the streets, you're trying to create addicts and trying to do that, and getting people to experience other drugs might actually become more of a problem in terms of addiction. We've talked about the contaminants leading to fungal infections and hypersensitivity pneumonias and things like that. That may also be a factor that hopefully will be less of an issue in company-bought cannabis. But, of course, the other side of this is cost. And what my patients tell me is it's much cheaper for them to buy it from the dealer down the road than to go through the process of buying it through one of the licensed producers. So that's the balance that they've got. And unfortunately, our patients with chronic pain are awfully financially disadvantaged because of their illness and do have this as a barrier. One of the hopes of legalization is that perhaps at some point this stuff will be covered by things like drug plan. But we're early into that process right now.
Dr. Hauptman, did you want to add anything more about street cannabis versus licensed producers produce their cannabis?
Yeah, I think the one thing is actually looking back at the individual. So it's quite clear that when a person is purchasing marijuana for recreational use, their intent is to get impaired. They're not there to, use it for the flavor or the craftsmanship of how it was made. They're certainly not concerned about any therapeutic benefit. They're there to get impairment. And in some cases, the more impairment for them, the better the product. Whereas the person who's using this for therapeutic reasons, whether it's nausea, whether it's sleep, whether it's anxiety, whether it's pain, they don't want, again, that impairment. I think for the vast majority of them, that's what they're trying to avoid. They're trying to use it strictly for a symptom that they're finding is not being managed at the present time, whether that's because they haven't gone to a physician or because what we have in our toolbox as physicians hasn't worked for them. So we're talking about two distinct populations of individuals, and that's why I think there's always going to be, in all fairness, these two markets. We've accepted as a society that the recreational market is there. A point of interest, by the way, we are the second country in the world right now that has legalized marijuana for all uses. So that's a really interesting fact, and I'm not sure what that means, to be honest, but we are truly the second only country in the entire world that has legalized marijuana for all uses. So we've accepted the fact that some people are going to use it recreationally, but we as physicians have to be aware of our patients doing this. We have to now become comfortable with making the diagnosis of cannabis abuse disorder, and we have to be comfortable with recognizing the potential side effects, just like we recognize the side effects of legalized tobacco, like we recognize the side effects of legalized alcohol.
So that leads us really to the overarching question, I think, which is whether or not physicians want to be involved or still be involved with the change coming with legalization, whether they want to be involved or still be involved in prescribing cannabis. The CMA, the Canadian Medical Association, has kind of washed its hands of this and said, no, we really don't want to be involved in this. Dr. Kaplan, what do you think? I mean, you are prescribing. Presumably, you've been doing this for some time. Are you going to continue? Is anything changing for you?
Well, this whole thing came in at a sort of back door, didn't it? All of a sudden, one day, this became something that physicians had to manage, and we weren't trained on how to do it. We had to learn it by experience, and we had to figure this out our own. It's not like we've had with other medications where there's huge randomized double-blind controlled trials. There's a company that's put a lot of investment into this and has then made sure to educate after they've done the trials on who the appropriate patient is and how to use it, what the pros are, what the cons are. Instead, this became all of a sudden the job of physicians to prescribe it. And they became understandably both frightened and angry. The CMA's position seems to be that why has this become a doctor's job to do if it's going to be legal across the board and anyone can buy it? It's like, well, am I going to start prescribing which kind of gin or vodka you should drink? Would be a similar kind of analogy, although it's not quite the same. So this is all quite controversial for that reason. I don't think clinicians were prepared. Legalization makes this much more complicated because what's my role as a physician? Why am I advocating or okaying a product in a prescription if the person can then go ahead and buy it on their own anyhow, because of what I say or in spite of what I say? I think it makes this very difficult. Yet other agencies like the Nurses Organization really want physicians to be involved because they want us to have some kind of, quote, control, end quote, on this. But do we have any kind of control on this if patients can buy this when they want to, as they want to, once it becomes legal?
Yeah, good point. Dr. Hauptman, what about you? What do you think?
Well, I agree with Dr. Kaplan. This is a very controversial area. I think we've seen some of the disasters in Canadian medical history by asking physicians to do things that they may have not deemed themselves well trained in, and this may have been part of the problem that led to some of the overprescribing of opioids, or quite frankly, the overprescribing of benzodiazepines. So we have to recognize just because we're physicians doesn't mean we clearly know everything. That being said, like it or not, we are going to have to understand this area, particularly for those people who are using it recreational and the potential health risks. So we have to get comfortable. I do feel for the pain patients who are looking for other alternatives, because what we currently have to offer them are not sufficient for their symptoms. So I think having physicians that are still involved here who understand the marketplace is important. I think if not us as gatekeepers for the medicinal side of things, who would be the gatekeepers? So notwithstanding the Canadian Medical Association's position, and I fully understand it, at the same time, this is the space that we find ourselves in. And this is not the first time that things have been asked of physicians that we feel uncomfortable with as a profession. Not to get too controversial here, but consider medical assistance in dying. That was actually thrust upon us by the Supreme Court of Canada. And we were said, hey, you're going to be the gatekeepers. And we reluctantly followed suit. So I think this is a similar situation. We have to respond to the pressures of society, and we have a responsibility to try to navigate this for ultimately the safety and, in some cases, the benefit of our patients.
Thank you both very much. I don't think listeners can still be in a fog, cannabis fog, whatever, after that. So we've taken a stab at these questions when we seem to get results from cannabis for pain relief. Are we seeing steak, or are we just seeing sizzle? Is cannabis suddenly in just because opiates are out? So Drs. Hauptman and Kaplan have told us where the evidence is lacking and what their experience suggests. Let's hope that with legalization of recreational cannabis improving access for Canadians, if that's a good thing, perhaps one good thing that will come out of it is eventually we will weed through the anecdotal reports and do more formal research to hash out just what we need to know about the analgesic properties of CBD and other medicinal properties of cannabinoids generally. I'm Dawn Rae Downton. Thanks for listening in on all our podcasts about how in a rapidly evolving or even sometimes devolving environment we can still treat chronic pain.
Thank you for listening. If you like this episode and want to hear more, please visit www.MDBriefCase.com and subscribe to the Get Brief podcast channel. Tune in next time for another exciting episode.